I think. Yeah, I think. Yeah, it is showing me as live now. Yeah, yeah, I'm. Okay. So we wait for 2 3 more minutes and then yeah, yeah. Then you let me know. You'll give me a call or should we just wait to start? Yeah, yeah, and WhatsApp. Yeah. So I'll just wait till the time. I'll put the same screen and then we can wait. When you say yes on the on WhatsApp, then I'll start. Okay. Good afternoon, all everyone who has joined me on this webinar topic of COVID era and retreatment in endodontics. First of all, I would like to thank uh, IDA team Bilaspur for extending me an invitation to lecture on this topic, and I would like to also like to thank the office bearers of IDA Bilaspur branch, uh, Dr. Lakshmikant Kashyap, Dr. Saurabh Bhandari, Dr. Priyanka Rai, for organizing such enlightening sessions. And I would like to congratulate IDA Bilaspur for doing a wonderful job as far as the continuing dental education goes. For everybody's information, I am Dr. Ashish Jain. I am an endodontist and I'm practicing in Navi Mumbai since 20 years. I happen to be the department head and professor PG guide in esteemed Bharati Vidyapeeth Dental College in Navi Mumbai, and I've been in academics and clinical practice since last 20 years. I run two clinics in Vashi and Navi Mumbai, and also I am a teacher as well. So yes, God has been kind enough for me to give me an opportunity to be an academician and enhance my knowledge. Uh, as academics gives a different ball game altogether. We get into some research work, some studies, and being a clinician also helps me in executing that knowledge in and imparting all that what I skills that I learn onto the patients as well. Uh, if I can start, I'd also like to thank Team Money, uh, Money Medical India, for giving me the opportunity to speak on this topic. The coordinator, Dr. Amit Rana, who is also the coordinator for this program, Mr. Ritesh Sharma, Mr. Shivam Sahai, for letting me the opportunity to speak to the esteemed audience. So, by not wasting much more time, I just miss the active interaction which happens between the members and myself as it happens in regular IDA programs. So, uh, saying hi to all the apple bearers. Lakshmikant Kashyap had called me up, Dr. Lakshmikant Kashyap, and he's apparently my student from Bharati Vidyapeeth. So, it was very nice of him to give me a call and remind me, because obviously it's difficult for us to remember all the students. So thank you, Dr. Lakshmikant, for just for a small introduction. And here I start my lecture. And the lecture is on the COVID era and retreatment in endodontics. So yeah, as we all know, last 6 months we have been suffering from this global pandemic, and it's been really tough times for everybody in the world, and not just India, but every top country in the world as well has suffered from this pandemic. So, just to be a short, I would like to also cover up about what will be required. My lecture will actually comprise of speaking about the COVID precautions in the clinic, COVID precautions while doing endo, while doing retreatments, okay, and also in general COVID era, what we are going to probably accept the change in life these days. So everybody knows this. This is a slide about COVID. It's a virus, okay, and its outbreak in Wuhan has really affected us severely. It's actually nothing but severe acute respiratory distress syndrome, which is SARS-CoV-2, and now it is officially called as COVID-19 because of a small change in its histology. So there is this virus who has got tremendous tentacles over it, and that's why it's able to attach it to the surface, and hence it is extremely contagious. So definitely we have all seen this. We have developed symptoms. Many of us have undergone probably the COVID infection. Some of them who have not undergone. We all know that yeah, there is fever, which is a high fever grade. Patients develop dry cough. There is shortness of breath. There may be sore throat. There may be headache, which may be concomitant with all these symptoms. The Center for Disease Control in US has added 6 symptoms to this. You also have got chills. They have got repeated shaking with chills. There is muscle pain also seen in cases of COVID-19 infection. There is headache, and also there is loss of taste or smell. So this is what us our patients would actually come and suffer. We should know this very clearly that if we see any of these symptoms in our patients, we are not supposed to encourage treatment in these patients. The spread of these infections is can be through what affects us is this aerosol generation, which happens in dental clinics. So we need to have distancing from the patient. Okay, so 6 feet distance. Okay, is what is mandatory for everybody around us. So distancing is the one which needs to be kept in mind. So definitely, this COVID has had a deep impact on all the dentists. Okay, it has been a global pandemic with devastating effects on the health sector. The health sector is affected because the medical people have to overwork so much. They have to really work very hard, and they are also affected with COVID. For dentists, yes, if we say there was an initial thought that yeah, there is a high risk of contracting infection through the exposure of saliva. We do are exposed to saliva. We are exposed to blood. We are exposed to aerosol. So everybody was scared because of going to a dentist, and that is what it affected us. And that is why since the lockdown started, dental clinics were closed down since March 2020. We all had closed down our clinics. Okay, and this led to a huge recession and lack of jobs and lack of pay all over the world and all over the country, and especially in India, because India we are a very niche profession, and that is why it was tremendously affecting all of us. So, but as unlockdown began, then what happened is that since things began opening up, most of the dentists thought, yes, we have to open up our practices. And as we open up practices, we have to know how to practice, what to practice, and to keep our patients and ourselves and our family members safe. So we had to be careful, and that is why knowing about the safe dental practice is the need of the hour. So the new normal would be we need to modify dental clinics. I'm going to take this in short or for the benefit of all of the IDM for all the members who are actually attending the lecture. So we need to modify clinics to an extent. We need to have certain protocols for dental patient management. We need to have a guidelines for ourselves. We need to modify the pre-procedural steps what we do. We also need to modify procedural modifications. We need to develop protocol for emergency treatment because in future we are going to develop or we are going to come across high risk patients. So there should be an emergency treatment protocol for them. We need to also treat the resolved COVID-19 patients. For example, if a patient comes to you who have had history of COVID, now what will you do with these cases? Are they in infective state? Are they not in infective state? So we have to know about that as well. Patient discharge protocol, when the patient discharged from your clinic, how you have to send the patient outside your clinic, disinfection of the clinic setting afterward the patient has gone out of the clinic, and also the waste management of this process of whatever we generate during the procedure. So in short, I'm going to take up all these topics and then I'll move on to retreatment per se, and then COVID precautions for retreatment, and then retreatment in particular. So dental clinic modification, everybody should be having safe distancing. So as you can see in the diagram that we need to have adequate distancing during sitting. So if you don't have a large waiting room, you need to call patients one by one. And if you do have a large waiting room, we need to maintain distance from the patient when they sit in the clinic. There is a immediate need to display visual alerts at the entrance of the clinic because patients are not so aware of what to do in the clinic, because we are all gone to the habits of crowding. We all crowd together. Still, if you go outside, you will see that we all crowd together. So we need to display visual alerts in the waiting hall and the reception area. As soon as the patient enters, we have seen everybody. We are supposed to wash the hands, sanitize, keep a pedal operator sanitizer. That is a must. Need to have a non-contact forehead thermometer and a pulse oximeter. Okay. The first and foremost step when the patient walks in before after sanitizing is that you will go for checking their thermometers, their pulse oximeter levels. Okay. And if the patient gives any history of fever, respiratory, or presenting with fever or any respiratory disease, you need to refer it to the hospital. Maintain distance and always wear a mask. Mask should always be up, never down. Then you need to have a screening form with you along with your regular screen form. You need to have a screening questionnaire in which you will ask the history and keep a record of this questionnaire, because this will be helpful whenever any municipal operation people approach you. Because if they approach you and they ask any history and you do not give this COVID negative history, we just may fall into some kind of legal trouble. So we need to be very careful whenever we are taking any history from the patient. Okay. In general, you should also add something like this. Try to remove magazines, articles from and toys from the reception area. Okay, all those trophies which we get during whenever we go for any lectures or as a memento, we need to start removing them from the reception area. We need to install a glass barrier at the reception desk. We need to encourage contact cashless payment. So please have QR code in your established in your clinic, or even you try to discourage even card payment, because even card payments require some kind of contact. So best is to have a QR code. Today even bhelwalas, even panipuri walas have got a QR code, launched at their shop. So these we can always go ahead and have a QR code installed at the clinic. We can try to avoid use of ACs, but it is not proven actually. But if you are having a HEPA filter with you, then there is absolutely no need. You can always use AC. It's still controversial whether to use air conditioned or no. It is recommended to use natural mechanical ventilation fans with exhaust if you are not using the AC. It is important that you use this natural ventilation and mechanical ventilation as well. Okay, so these are what HEPA filter looks like, or you can see the right side. Okay, so this HEPA filter is like this screen, a whitish screen which you see in a HEPA purifier. We can use any of the HEPA purifiers. There was a huge rush for sharp purifiers in Mumbai, at least when I was supposed to buy in first week of May. And now there are many of the purifiers which come with HEPA filter, and this is what I think is a must in a clinic. Okay, you can install extra oral suction devices as well. It is recommended, but not compulsory. Because I think if you have a good suction in your clinic, that should serve very, very well. But if you are paranoid, if you are scared, if you can afford that space, you can install a high vacuum extra oral suction. HEPA filter, I would perceive as a must, and you can actually feel that if you use HEPA filter, the air in your clinic, suddenly feeling you start feeling the pure and fresh air in your clinic. I personally experienced it, and I loved keeping HEPA filter in my clinic because I could feel breathing fresh air every time. UV light you can use, you may not use, recommended, but yeah, but if you use it carefully, good enough. If you have not don't have trained assistants who could use UV light, then you can avoid as well. Strong exhaust is always recommended. So after once the patient is done, you have to use a strong exhaust fan, and you need to maintain natural air circulation within your operatory. This is another addition. We need to have an extra room where you would use a PPE. I mean, not all details of PPE, but yeah, you need to don and doff the PPE whenever we use it. And that's for me is actually the key, because I have tried to remove the PPE wearing the jumpsuits, and it was quite difficult for me. So then I moved on to the gowns actually, because gowns are actually more preferred for us right now, because we can remove the gown without touching the internal surface. So I've been wearing a scrub suit first and then a gown on the top. We can always go for reusable gowns, and need the problem is where to take off these gowns. Okay, so you need to take off the gown properly. So you need to have a small place. It can be your toilet, or it can be just beside your toilet, where you need to don and doff your PPE. Okay. Then protocols for dental patient management. You need to have a triage, as popularly popularized by all the eminent speakers of the country. Triage is by you will give them a call, or you talk to every patient on the phone first, and you prioritize the emergency care. So you have an emergency care, you have an urgent care, and you have a scheduled elective care. Yeah, initially days of our practice, we were only dealing with emergency care, but now 3 or 4 months down the line, we have actually moved towards even scheduled elective care of the patient. Okay, so if you see this, when the patient comes in, you need to have a tele-screening, or we can have patient evaluation right at the reception. If the patient gives you signs and symptoms of COVID-19, okay, then you need to consider that patient as suspected COVID patient, and we need to report it to a local or healthcare agency, maybe advise a CCT test, or maybe you refer him directly to the hospital. Okay, And in that, you may have three types. Okay, now suspected COVID patient, you may be required to do emergency care. You may be required to do urgent care, which may have a acute pain and swelling. We don't consider urgent care as emergency care. Okay, because urgent care is, yeah, patient is having pain is urgent care. It's not an emergency. Okay, we can always manage with antibiotics and analgesics. And elective care, where patient has got problem in eating. So in those cases, you need to have elective care, like old patients who need dentures at that time. We have to even provide dentures also, right? So that comes under elective care, right? So you can go ahead if it's an emergency care and you suspect it's a suspected 90 patient, perform immediately. You need to perform this treatment in a negative pressure air room. Okay, so you need to have a purifier, you need to have good ventilation. If at all you find it's an urgent care, then you can try and manage with antibiotics, closely follow up with the patient. And if this patient is turning into an emergency, if any Ludwig's is developing, any unbearable infection is developing, then you need to change your stance. Okay. So the pharmacological management, everybody knows that we all prescribe many antibiotics, many painkillers, but antibiotics we all limit ourselves. Normally, everybody limits to amoxicillin and oxalic acid, probably the most popular antibiotic that we all are using. In cases of anaerobic infections, you just may go in for metronidazole or tinidazole, 4 milligrams, 8 hourly. And in cases of patients who are having allergy, we can use erythromycin. If not erythromycin, we can always use clindamycin, which is slightly more powerful. In cases of analgesics, we can go for paracetamol, very, very popular painkiller. But along with that, we can add ketorolac. We can add piroxicam if you want a long-acting painkiller. Ibuprofen, yes, it was said before that ibuprofen is contraindicated, but still controversial. But as of now, because it's controversial, we may not use ibuprofen at all in our practice, and because of conflicting research over this. So as far as possible, we can avoid ibuprofen till concrete research comes into play. Okay, so let's go fast on this. Hand hygiene, we all know, every general man should be knowing the steps of hand hygiene and the usage of PPE. Okay, so properly covered PPE along with the gown and an N95 mask or an FFP2 mask is what is recommended for the dentists. How should we put on the equipment? First, we need to put the gown first, then we put the mask, the respirator, then we go for the goggles or the face shield, and then we wear the gloves. Okay, now this is the order. It's important to follow this order to limit infection to you. While removal, we need to go for gloves first. That is first set of gloves, not the second set of gloves. Then we remove the goggles, the face shield, then we remove the gown, then we remove the mask respirator, then we remove the second pair of gloves, and then we wash the hands immediately in an alcohol-based sanitizer. So this is given by the Center for Disease Control, and this is standardly accepted all over the world. Okay, so this is done. Yeah. As far as the procedural modifications go, yeah, every patient who walks in, we have to go ahead and give him a mouthwash. Okay, now this mouthwash can range from povidone iodine to chlorhexidine to hydrogen peroxide. But as of now, most of the research says that povidone iodine or betadine is one of the best microcidal agent for neutralizing or reducing the virus in the mouth, right? So you should prefer povidone iodine as far as ointment goes. But there have been research where people would recommend chlorhexidine, people would recommend hydrogen peroxide as well. I have personally used hydrogen peroxide in my clinic, but it's very tingy for the patient. Even povidone iodine is slightly bitter to the patient, but more acceptable to the patient. Okay. So when we come to conservative as such, as I mentioned, that we can go for mouth rinse with povidone iodine or hydrogen peroxide. Use of a rubber dam becomes a must for all of us. Okay, because this actually limits a lot of aerosol coming mixing with saliva. That's the biggest advantage of rubber dam, and that is why, as you see, there have been stream of lectures on rubber dam in the country. And believe me, rubber dam is not at all difficult to apply, to use. When all of us can work 5 mm inside the tooth, we can work 20 mm inside the tooth. Why? It is just applying a rubber sheet on the tooth. That's it. In fact, rubber dam is as simple as that. And we need to hold it with a instrument. So it is not very difficult. We'll come into the rubber dam details in short. Then you should try to use hand instruments for caries excavation as far as possible. If you are not comfortable using, if you are having problems in your high-vac suction, your suction is not very good. At least you can remove the caries, expose the pulp, probably put some agent in it to reduce the pain. Use high vacuum suction tips. Okay, now this is where it's very important to take up all the aerosol, and the aerosol exposure will be very limited. And as far as possible, if you can use disposable air rotor, or you can use anti-retraction handpieces. Okay, so this is where we need to slightly change. They're slightly more expensive handpieces, but in the long run this will also be helpful for you in practice, right? So what we should do is just start applying the dam in place. Okay, this is in short is what I've taken up for the conservative scenario, for apical abscess, for pericoronitis, for pulpitis. There is something called teleconsultation, there is urgent care, and there is emergency care. I may not go into details of this, but this is what is normally done. We first prescribe analgesics for abscess cases. We advise antibiotics if there is systemic infection, and we call back the patient. Okay. If they do not resolve, then we go ahead and do incision and drainage, or we extract the patient if the patient is not keen to save the tooth. Okay. If it is an emergency care, okay, then we'll have to refer it for emergency care to a designated center if there is any airway compromise happening. So similar to that, I think there are all of them, which the first two of them require the same care. For pulpitis, it's slightly different. We just need to prescribe the patient, and after that, we need to open up the root canal. Okay, so once you opening of the root canal can be done with the help of chemomechanical caries excavation. If you don't have a rubber dam, use a rubber dam. You can always go for high volume evacuation, and you can use the air rotor and do pulpotomy for pain relief. This is what can be done for the patient. Okay. Okay. Now we come to management of resolved COVID-19 patients. So we do come across patients who have suffered from COVID, and now they will start coming because they have recovered from the hospital. So there will always be slight amount of question mark amongst all the dentists' mind whether he is in infective state, whether the viruses are obviously present inside the human body. So we'll have to take a non-test based strategy or a test based strategy. So what is a non-test based strategy is that at least 3 days should have passed since recovery. So there should not be any symptoms, improvement in respiratory symptoms or cough, nasal, short breath, and at least 7 days have passed since the symptoms first occurred. So this is in general a non-test based strategy. What you can apply this if you are not going to go ahead with a test based strategy. Now, what is test based strategy is that there should be something called symptomatic COVID patients and asymptomatic COVID patients. If you have got symptomatic COVID patients, they should have a nasopharyngeal swab which is negative. Okay, so it is two consecutive nasopharyngeal swab specimens collected 24 hours apart is what is a test-based strategy for symptomatic patients. And if the patient is asymptomatic, then we need to wait for 7 days more, because first same what is the non-test based strategy is applied. So if the patient is not having any symptoms, please wait for 7 days more after the date of the first COVID positive test and has no subsequent history of illness. Okay, so this is what should be the strategy for resolved COVID-19 patients in short. For patient discharge protocol, whenever you finish the treatment of the patient, please remove the drape. Drape has to be removed by the assistant. The patient has to perform the hand hygiene immediately because the patient has touched probably here and there, or you give the gloves to the patient beforehand. Then you need to record the prescription, and follow-up instructions should be done only be after docking the PPE. So first you get up from the chair, take off your PPE, and probably if you can take him in another room, and then you will write the prescription. After that, there is general cleaning process of cleaning the floor with 1% sodium hypochlorite. You have to use separate mops for the clinical area and separate for the reception area. Then, ideally, the floor should be cleaned after every patient. Okay, and wash and disinfect the mop also with 1% sodium hypochlorite and leave it in sun for drying. That's the best place where the things can dry up. That's the natural sterilization. Rest of the dental surfaces should have be cleaned with 1% sodium hypochlorite. Okay, and delicate electronic equipment should be rubbed with alcohol-based spirit and swab before each patient. Okay, you can always fog your clinic. Okay, it may not be required after every process, but at least at the end of the day, once your day is over, we should go for no touch surface disinfection, where we use hydrogen peroxide stabilized with 0.01% silver nitrate, and we perform the fogging. Or we can use something like chloride, which is just a tablet, and it'll for 4 hours it will be acting. Okay. Coming to waste management, we need to use this waste, since waste management becomes crucial. If there are any positive COVID patients, then we need to properly pack the bag. Now, double plastic needs to be used for COVID patients, not a single plastic. That is the protocol given by the biomedical waste company these days. They take up in two plastics, because even if one tears, second, the affected carrier should not be exposed to the waste. So this also becomes important for us to know that please give it in two plastics. Okay. So in short, this was about the COVID applications for us. Is that we need to be careful, and once you think of treating a case, whether it's retreatment or endodontics, let us come to conservative in particular. So we need to start using the rubber dam. Rubber dam was as invented by S.C. Barnum in 1864. Way back, imagine his foresight, his thought process, that nothing changed. For the last 150 years, nothing changed, and it really, really helps you in practicing great dentistry. In short, what are the advantages? Yes, it gives you a dry, clean operating field. So imagine no saliva coming in, no tongue coming in, no cheek coming in, and believe me, it's really, really becomes very easy as long as you have a good assistant who helps you in taking up all the waste that you create. It gives you improved accessibility and visibility. You will be surprised to know if you are working in an upper lower 8 or a lower 7, and you see keep the tongue keeps coming, you retract the tongue, you retract the cheek. As soon as they put the dam, the tooth suddenly becomes so accessible and visible that we can actually perform the root canal treatment in far better way compared to what was before. You just have to do it once to realize it. Improved properties of dental materials, yes, because of no contamination, your properties are improved, your treatment becomes more successful, and it gives you protection to the patient and operator. Okay, all the instrument are you using, nothing going to go inside the mouth. There's a lot of safe passage of the instruments from the mouth and outside, so it really gives you a lot of safe safe attitude of the patient and of the operator. It also increases the operator efficiency, because there is no need to wait. There is no patient doesn't spit, patient completely forgets. Sometimes patient goes to sleep even, and your work becomes far more faster. It doesn't come with its own disadvantages, yes, because sometimes it damages the marginal gingiva and cervical cementum, because when you put the clamp, it just impinges on the gingiva sometimes, because you need to have a good secure, because if it's broken down tooth, you need to go slightly subgingival. Yeah. Then there are metal crown margins or ceramic margins we get chipped off when we put up a clamp on a adjacent tooth which has got ceramic. So yeah, it can happen. Please inform the patient about it, and you can always repair it. And the one more problem is, what you have difficulty taking radiograph. So we have to actually remove the frame. That is the only disadvantage. But if you actually align the clamp properly, then normally we can always see the effects, which is of prime importance during this canal. So this is what the entire kit looks like. Okay, you have the entire box of clamps, you have the rubber dam punch, you have the rubber dam sheets. Let's go to details of one by one and by each. So where conditions where you have difficulty in using rubber dam will always be, yes, you will be partially ruptured teeth. Okay, like young patients coming in, partially ruptured and it's carious. Yeah, because of the convexity of the surface, we have sometimes problems in putting up the clamp, but it's all possible now. Some third molars, the upper third molars, where the masseter comes into play, so at that time it becomes difficult. So if you're not able to, you can always inform the patient about extraction. Extreme malposition teeth, I'll show you some photographs on extreme malposition teeth. It's difficult to put the dams. The clamps interfere. Asthma patients also can have issues. Okay, and we cannot risk their airway obstruction. So please take a history. So at that time, the airway obstruction is more important for us. So you can always avoid a rubber dam. Yeah, more often than not, we come across claustrophobia. Some like a rubber sheet around your mouth is very disturbing to the patient, and if we psychologically manage the patient, I think you'll be able to perform the procedure. Latex allergy is seen in some of the individuals where if you have a patient is suffering from latex allergy, obviously you have to use non-latex based sheets. It's a far and few, but yeah, you get silicone sheets and you get polythene sheets as well. Okay, so you may come across difficulty in isolation in cases of severe root caries where you will not be able to put the dam. Okay, and you may not be able to, if the edentulous area is posterior to the tooth to be treated, then it becomes difficult because you are supposed to clamp the tooth which has to be treated, then it becomes very difficult. So these are some difficult cases which, but they are far and few. So obviously, if there are far and few, if you can perform 90% of the cases with rubber dam and 10%, that's perfectly fine. Okay. So we have various sheets available in rubber dam. We have got thin, medium, heavy, extra heavy, special heavy sheets. Okay, if it, normally we use always medium to heavy sheets for most of the cases where there is adequate retraction and spreading of the sheet, but we use sometimes special heavy sheets in case of class 5 cases where you need to retract the attached gingiva as well. So for retraction of attached gingiva you require extra heavy or special heavy sheets. Okay. This is the frame that you come across. Okay, the frame can be plastic and frame can be made up of metal. It doesn't make much of a difference that it is plastic because it's all about longevity. Metal will last more probably, but slightly obstructs during the time of X-ray. So if you want to take an X-ray, you need to remove this frame and plastic frame need not be removed. It's also foldable. So that is what a dental dam frame would be like. Okay, and you also have got template with it. So you have a template in which gives you easy marking, so you can easily mark your tooth hole where. So if you want to like do a mandibular incisor, you need to mark where it is given for that little incisor. So this template always helps. It doesn't waste your time in marking the hole and punch with the help of a punch. Basic things. Now you have the clamps on this over here, and these are the various types of clamps available. Okay, and the clamps can be made up of metal, plastic. Okay, they can be metal, can be stainless steel or can be carbon steel. Normally we use the stainless steel ones, but now they are also available in fiber like plastic, so it is radio lucent, so it doesn't interfere in any of your X-rays. Then for posteriors, you have the single bow like this over here. You have a single bow for posteriors, and you have the double bow for the anterior. So if you see double bow one, it is meant for anteriors. You're going to grip the tooth from here, and you have for posteriors, we have got a one with a single bow. Okay, clamps, they can be of two types. They can be winged, they can be wingless. Okay, the wing ones are the ones which has a small wing over here. Here, this is the wing. Okay, this is the bow, this is the wing, these are the jaws. Okay, so this is where it goes and clamps the tooth. Okay, and this is where your wings are. They are made for additional retention of the rubber dam sheet. Okay, but this is a bit of a problem in the upper 7 or upper 8s because of the masseter. As soon as the patient opens, the masseter comes ahead and it interferes. So in those cases, we'll start using wingless clamps. Okay. There are various types of clamps for anteriors. As you can see, number 9, W9, we have molars at W3, W7. Okay, this is mainly for seen in the 14 ones. Then you have for bicuspids, we have for serrated. If the teeth has less of convexity, then we go for serrated ones. Okay, they give you more teeth for retention. Okay, and if you have irregular teeth, then we have got small and large, and they are aligned in a different way so that we can put the clamp on partially erupted molars as well. Okay. So if you see in the photograph, please do not go in for a very large clamp. So take a clamp and always put it onto the tooth. So once you put the clamp on the tooth, you will see whether it is probably confining with the tooth shape. Okay, and if it is large, please go for a smaller clamp. Okay, it should not just hold on to the tooth in the center. It should be at the line angles. Okay, so when you have these line angles, okay, it properly grips properly well, and it does not impinge on the soft tissue. So this is where you need to check whether that your clamp size is proper or no. And today it's not really expensive. Even you have got all the cost-effective clamps which have come over. We can get clamps 500 rupees for 600 rupees. Very, very good quality clamps, and you can have a range of clamps for every uh, case. Okay, we also need to tie a floss to the clamp, because sometimes the clamp slips inside, or sometimes it just may break, as seen in the photograph over here. So by chance, if it breaks, if you have a tied a floss to it, then normally we can easily retrieve it, and it should not go into the throat like this, right? It sometimes happens, it just flies through, because it is like a very tight metallic. It's just disclamps from the tooth. So we need to be careful. Just tie a floss to it. These are the various ways we can tie a floss to the clamp, and we can always be safe as far as the disclampsia goes. Okay. There are various methods of placing rubber dam placement ways. We can. I will share a small video of 14 where the operator has shown it very well how to go about doing quadrant isolation. But we can go in for a single unit method if you are doing rubber dam isolation for endo, and we can go in for multi quadrant isolation if you are doing restorative. Okay, single tooth is a no-brainer. Absolutely, you can always go within like 1.5 or 2 minutes. You should be able to put the dam. Okay, it doesn't really take. You just have to know how to do it. Okay, that's it. That's the only thing which is required. Yeah, these are the times where you do quadrant isolation. As you can see over here, when you do restorative work, sometimes you have got malposed teeth. So this is the problem where if the teeth are malposed, then that's the time where we need to put clamps in proper position, and it becomes a bit difficult. Sometimes the tooth is broken down like this, we just make a slit in the center and we do something called a split dam technique. So yeah, this also helps because there is no saliva coming from here. Okay, we cannot put a clamp on this tooth, so we use the adjacent area to clamp, and we put the sheet around the tooth. So this is the small video. Okay, I think there is no mute. So this is where the W3 clamp is there. You have the W3 clamp over here, and you have the W8A clamp. These are all wingless clamps. As you can see, is Dr. Mario from Switzerland. Okay, so this this called is a wedget. Okay, and this is the stainless steel frame which is used. This is the rubber dam sheet, and this is the clamp forceps in which you hold the clamp. Right, this is the punch. You have a larger hole for molars, and you have smaller holes for premolars and for premolars and for maxillary anteriors and mandibular anteriors as well. So you punch according to the template. Okay, then is punching multiple holes. You can always mark with the template. Okay, I prefer to mark with the template on. It's easier for the beginners. Change the size of the hole so that it confides to the size of the tooth. So this is what he is showing as quadrant isolation. This is a wingless clamp. As you can see, you just put the bow on the posteriormost part of the tooth. You can fold it and see it very clear. You can easily see the wings. We can see the jaws. So just stretch it, and now place it with the bow going separate with the distally. This is done, and now we just stretch all the holes on the tooth. So that's number one. We go on to number 2. You can always put the frame so that there are no folds which come onto the. Now he has put on the rubber dam frame, so that it's easier for us to stretch now. You can see it very well. Okay, so now we'll stretch it onto the remaining teeth, and this is the entire quadrant is isolated. Now take a floss and we always try to push the sheets between the teeth. Okay, so it's important for you to know whether the contacts are clear or no. It has to be examined before. This is the wedget, okay, which you can put onto the anterior portion of the isolation. Okay, and when you want to remove the sheet, at that time you need to cut open and remove the. Please do not remove it directly. It just may hurt the patient. So this is where we can do something called as clamp modifications. Okay, sometimes if your teeth are not exactly, if your teeth are not really confining to the tooth, sometimes we reduce the mesodistal reach of the tooth. So we mark it and we reduce it with the help of a burr. Okay, we can always even sharpen the tines of the beaks. So you have such sharp serrated jaws which may get blunt over a period of time. So we can use stones, okay, and we can always sharpen these tines. We can always even remove the wings. If you have a winged clamp, we can remove the wings of the clamp and convert it into a wingless clamp. Okay, so this is, and sometimes for anteriors, what we require is if one bow is obstructing your work, then we can always cut with the help of a burr and just keep one single bow in cases. So the regular investment what needs to be done in your clamps. Clamps we need to keep buying sometimes, because yeah, it should not break in the midst of a procedure. So we keep checking your clamps and modifying if required, and a regular investment for clamps. Okay. In addition to the putting the dam sheets, we can always put some additional flowable tissue blocks, okay, where which will give an additional seal to the patient. Then we have something called a pre-treatment build-up, but what we normally do for endodontic purpose. If the tooth is broken down, we prefer to do a pre-endodontic build-up. In that case, we need to build up the tooth structure with the help of composite material. So we put up a copper band or any band which you are comfortable with, build up the structure and then put the clamp, because we cannot put a clamp in a broken down tooth. So either we do use a split dam technique as shown in the photograph before, or we can isolate, build up this tooth and then place a clamp on that. Okay, this is like pre-endo half build up. We will do a half. If half is broken down, we do a mesial build up and then we go and proceed with the root canal treatment. Accessories, as I showed you, there are dental floss, you have wedgets, you have rubber dam napkins, and you have rubber dam lubricant additional if required, but most of the time it's not required. We can always use this. Floss and wedgets come. Floss is always available, and wedgets comes with the sheets with the kits. Okay. There are certain advancements in rubber dam. We have got prefabricated sheets with the frame. So now they are in various trade names like Dermadam, like Instidam, like Flexidam, like Optidam, Handydam, or Optodam. Okay, they are slightly more expensive. They come for 100 rupees per sheet, so slightly more expensive. But I think you can easily go ahead with normal sheet because they are more tailor-made to every situation. These are slightly more expensive. Yes, if you don't have the time, you are a very busy practitioner, you can go for Optradam or Optidam. Okay, And in addition to that, we can put some seal onto the adjacent tooth structure for any liquids to come through. The photograph in the right is called as isolite method. Okay, now this is a basically an inherent suction machine. Okay, which with an attachment where it retracts the cheek, as you can see, it retracts the cheek also, it retracts the tongue also, and there is an inbuilt high vac suction in this attached to your suction. So my friends in America and all, they are pretty popular. They are very happy with isolite. People who don't want to use rubber dam, who don't have the time or inclination to learn, they use this isolite. And the only thing is, the saliva is kept out, but only problem is the gingival clavicular fluid, which keeps seeps in for a class two, is not we're not able to keep that out. Otherwise, it's a very good instrument for keeping the saliva out, and also there is tongue retraction and cheek retraction, as you can see. So this is also one of the um, equipments available for adequate suction. Now this becomes a very important tool in cases of practice. Okay, so this was about all the isolation purposes required to start any endo purpose or any retreatment required. Okay, now there is no special uh, indication or a special procedure required for retreatment in endodontics. We need to diagnose the case well. Okay, it's not changed anything post COVID or pre COVID. Retreatment remains retreatment. Okay, whether it is now or whether it was some years back. Okay, so retreatment is basically a process in which we have encountered a failure now. Okay, and now this involves removal of root canal cleaning materials from the tooth. Okay, now why this is more challenging than a natural tooth is that because there are obstacles inside. The God has given a natural glide path to when you do a fresh root canal. So all the curvatures can be negotiated because there is a natural glide which where you can actually take in all the instruments. But once the tooth is filled up or it has been modified by a dentist, then it becomes difficult because the natural glide path is gone. That's why treatment in endo is always more challenging than regular treatment. Dr. Skildar quoted the term retreatodontics because he actually perceived and way back in 1986 that he thought the future of endo lies in retreatment of endodontic failures. Because yeah, endodontics started way back in 1950s, 60s in those countries probably, and in India probably in the 1980s is there when real endo caught on with the dentist. And now it's now that we all start encountering failure. Okay, since 20 years of my practice, I see my own failures, I see others' failures as well. Okay, so now we start coming across how did your treatment unfold, whether the case was successful for 2 years, 5 years, 10 years, 15 years. The cases even fail after 12 years. Okay, like I have seen some cases where after 12 years the failures began and what we came across was a vertical root fracture. So we are going to encounter cases where your instead of fresh root canal, we should be good in treatment of endodontic failures because then that will increase the faith of the patient on the dentist. If at all you do any kind of root canal and it fails after 5 years, so somehow the patient memory is so limited and he feels that what was the use if my teeth was going to fail after 5 years. They don't consider 5 years as long term somehow in dentistry, which is very bit surprising. So Friedman suggests that we should not call it as a treatment failure. We should always term it as post-treatment disease. Okay. For example, if there is a bypass failure by a cardiologist, they don't term that as a failure, right? They always say that now retreatment is required. So similar to that, we all dentists, we should not refer it to as a treatment failure whenever any failure is reported to you, whether it is your friend's failure or your own failure. You can always term it as post-treatment disease, and probably the patient will understand that why is it called as post-treatment disease. That we have done the treatment to the best of our ability, and after 5 years, it is showing a failure. So it is disease which is present post-treatment. Okay, now this is the biggest controversy which comes into play for all the dentists, for all the graduates, for all the postgraduates. That should I extract or should I go in for an implant or should I do a retreatment? So as we see, implant cases have show a lot of success rate as well. 98.4% for average follow-up of 36 months. Okay, while endodontic retreatment gives a success rate of 99.3%. So why not go ahead and do endodontic treatment or why not go ahead and do the repeat treatment? Okay. For example, if you are going to do an implant, okay, after probably 4 years or 5 years, you are going to encounter such dehiscences. Okay, it's very very common, not very uncommon. Anybody who has done implants for last 10 years, okay, like I've been doing implants for last 12 years, and yes, these are the things which we actually come across. Okay, now this is what a photograph for case. And if you come across these cases, you have to inform the patient that implant is going to fail within some time, and you need to take corrective procedures to correct this. Okay. Same thing in a tooth. If you're going to encounter such a recession, okay, you need not worry at all. This is not going to fail. Tooth is a tooth is a tooth. Now see this cadaver jaw. Okay, now we will regularly come across such kinds of fenestrations and dehiscences in the practice. If you open up a flap anytime you perform an episectomy, you'll probably realize that you will have such beautiful fenestration, and these teeth are extremely healthy. These all these teeth. But the same scenario in case of an implant. Imagine if there's a dehiscence in an implant exists. No way an implant would survive. Okay. That is why my advice or anybody's advice would be to obviously save the tooth come what may, whatever possible, because the bone, the response to the tooth is extremely kind compared to the implant. So your tooth will actually last far more than an implant in such a case. And these are very common. These dehiscences, if you open up an anterior tooth anytime, you'll find these dehiscences very, very common. Okay, that is why try to save the tooth as far as possible. So when does the endodontic failure happen? It happens because of bacteria, because of fungi, because of extra canal factor like actinomycosis. It happens because of extra filling material. It happens because of presence of a cyst or even cholesterol crystals. Okay, it can also fail because of presence of a root fracture if it is present. Then if it may happen because of incorrect diagnosis, primary treatment. Sometimes you may see a periapical lesion which does not change in size, it just may be a scar. If it's a scar, there is absolutely no need to retreat, and we need to diagnose that whether it's a scar or a periapical lesion. And patients also may develop some neuropathic problems post root canal, which may be countered as a failure also. So why does the treatment fail? Yes, number one is probably poor aseptic technique. If you don't sterilize instrument, if you let the saliva come inside every time, yes, you are going to encounter failure because of aseptic technique. If you don't use the irrigant well, okay, you don't use extra volume of irrigant, obviously irrigant is where it's going to go all over the place, and that is why good ample amount of irrigation for 10 minutes or 15 minutes is the key. If you miss a canal, yes, if you're going to miss a canal, the case is going to fail sometime or the other. Most commonly, the MB2 canal. If it is missed, obviously, it is going to fail. If not now, after 2 or 3 years. If at all you are unlucky and your bacteria is resistant, if you introduce E. faecalis inside your canal because of salivary exposure, yeah, now it is going to fail. If you're unable to prepare the canal, if you don't prepare the canal well, in sense, if you don't shape the canal well, it is going to fail. It is going to fail if you don't obturate well. If you do some procedure errors like perforation or broken instruments, eventually it will fail. So that is where we need to know and we need to develop our skills so that avoid failures as far as possible. Some studies say that periapical repair it doesn't happen so fast, so we cannot base our decisions on say 1 year follow up or 6 months follow up. So we need to observe the tooth over a period of time, and and age also is also responsible for the failure rate. The Washington study says that it is high. The failure rate is high in cases of first decades of life, the failure, and in the later decades, 6 or 7 decades of life, and it's lower in patients with second or fifth decade of life. That means if you have a younger patient, yeah, the success rate is better after 10 years of age. So this is where you have to keep it in mind and probably convince the patient and tell the patient that you are a candidate for success or maybe a failure. So you always get to know about the details of this. Okay. Major factors, some studies, like Toronto study in 1993, it was a prospective study for 4 and 6 years. They performed the postgraduates in endodontics performed root canals, and they were observed a period of 6 years. And they found that if there is a periapical lesion, then the chances of failure are more. So you have to know this. So if it's a vital case, success rate is far higher. If you have a lesion, it may fail. Okay. Then second is technique and quality of obturation, because the obturation defines how the preparation is. So if the preparation is good, obturation is good, the success rate will be far higher. Extension of obturation, okay, a short or a long obturation. If you are within 1 millimeter of the tooth, then yes, your success rate will be high. If you are beyond or short more than 1 millimeters, your success rate will always obviously be low. Observation period. How does this change success? Any cases observed over a period of 6 months or 1 year is not the benchmark for success. Success, if you increase the time period, you will actually come across more failures in your practice. So, what is the most common cause of failures during uh, endodontic treatment is the presence of this bacteria. Basically, it is E. faecalis. Okay, you have other bacteria also like Streptococcus anginus, like Streptococcus tonsillitis, like intermediates, but the most common number one cause, if any researchers have found out, it is E. faecalis. And E. faecalis only enters from the saliva. Okay, it is not inherently present in any carious structure. Okay, it's not present in caries, it's not present in the tooth or in the gingival sulcus. It is only present in the salivary content. Okay, and if you are going to expose the salivary content, then you're going to encounter failures, and that is why application of dams becomes even more important. So uh, there are four options if you come across a failure. Okay, it will be mainly review or do nothing, either you perform root canal treatment, or you extract, or you refer. Right. So when will you review or do nothing? Okay, there is a time where you will come across a failure and you need to check it out. So if the patient is having no symptoms, okay, if the tooth is symptom free, patient not having any pain, any issues, the best option would be to review, inform the patient that there may be a failure. You may be seeing a failure, you may be seeing a periapical lesion. Better that we tell the patient that this kept to be kept under observation. If there are no chances of future disease, if you see a good, nice coronal seal to the patient in the crown, then we need not go ahead and jump into retreatment, because it may, if you create some problems, then you will be in a spot of bother. If you do not see signs of inflammation, no pain or percussion present, okay, then please do not go ahead and do root canal repeat treatment. Okay, and if the root canal treatment is recently been done and the outcome is uncertain, so if somebody has done a root canal maybe 6 months back, and there is a periapical lesion, the patient comes to you from somewhere. There is no point in doing the repeat root canal, because this tooth has to be kept under observation. So, example, a radiograph like this. Okay, a reasonable filling, not a great quality of obturation. You can see a small periapical lesion in the mesial root and a crown on the top. Now, this patient having no symptoms, please do not go ahead and do any kind of treatment. Okay, if the patient is having symptoms, there is swelling, there is pain or percussion, then only you should go ahead and do repeat treatment. Otherwise, you need to review, do nothing, keep the case under observation. If you come across proper symptoms of failure, in which there is no sinus tract, there is presence of swelling, okay, and if you find the tooth is restorable, you can go ahead and do non-surgical treatment. That is, if you see come across a short filling like this, okay, the short filling, there is an obvious development of a lesion, okay. You can see that there is some kind of crown on the top, some blackly crown, or maybe a composite filling. So you can easily go ahead and do repeat root canal treatment in such cases, and you can easily do a non-surgical treatment in this patient. When should you go and do a surgical treatment? Surgical treatment is not very often done by dentists, but I think in today's day and age where we are performing implants, why can't we do an apicectomy? It's not as difficult as an implant. In fact, like if you can deflect a flap, you can grind bone, you can always go to the apex of the tooth, remove the apex, as long as you have some surgical skills, which is actually quite adequately present in most of the dentists today who are performing for last 3 4 5 years. So you should go ahead and perform surgical treatment rather than going for an implant. When a root resection is required, if you have two roots and one other root affected, you can easily go ahead and do hemisection. We come across to those cases later on in the presentation. And if at all you come across that when biopsy is required, yes, you can go ahead and perform surgical treatment and take the yeah. So this is like the case where you will see that there is a crown on the top, a good crown, and you see there is a developing periapical lesion. Now here the entire disassembly of the crown of the post will be very difficult. It's better that we can always perform a, and if you have done the RC and you are sure about its performance, you can go ahead and do episectomy as well. We can always go for an extraction if you find the tooth is non-restorable or if the porcine core is also failed, and we can go in for a non-strategic tooth like the third molar. And refer if at all you find that it's not you don't have the requisite skills, you're not able to make a diagnosis, you can always go in for a referral rather than complicating the case. So this is the same as before. Indications uh, is where if you see a periapic radiolucency of more than even after 4 years, like if you see a radiolucency and after doing the initial root canal treatment, if the periapic radiolucency is there even after 4 years, you should go ahead and do repeat treatment. If there is tenderness to percussion, the apical penile pressure, any kind of sinus or fistula, swelling in the soft tissue, okay, and we should go for incomplete root canal filling for prosthetic restoration if it is asymptomatic. If you're finding you're going to restore it and it's been open for a very long time, then you can go ahead and do the repeat treatment. Retreatment is completely contraindicated in case of vertical fracture. Yeah, if you come across a VRF, okay, it's not indicated at all. If the periodontal status of the tooth is not good, then yeah, you can always go for extraction rather than doing heroic endodontics. If the tooth is non-restorable, that means you cannot restore it. The destruction is subgingival, more than 2 millimeters. Yeah, then even a CLP cannot be done. Then we should go for extraction. Access is difficult. If you cannot access the tooth, please do not go ahead and do re-surgical re-treatments. If there are patients having TNG dislocations, yeah, because re-treatment requires long treatment times, 3 sittings, 4 sittings, maybe long treatment time because you need to search the canal, you need to remove the filling, it takes time. If there is replacement resorption is where the tooth is being eaten from inside, you have to go for extraction. And if there are anatomical locations and non-strategic position. Okay. Now let's come to a step where we need to remove this E. faecalis bacteria. Now this is considered as one of the most resistant bacteria. Okay, so in this case, what is requisite is first of all you should go for a good aseptic technique. As usual, you need to have a pre-treatment rinse. Either you can put an iodine now in cases COVID times, or we can be having a chlorhexidine rinse. Okay, disinfection and application of dam is a must. Okay, increase the apical size preparation. You have to increase the apical size preparation twice, 3 times, and you have to use higher concentration hydrochloride. You have to use EDTA and you have to use 2% chlorhexidine as a solution. Okay, if as a last irrigant, and you can always use intracanal medicaments. You can use 2% chlorhexidine and calcium hydroxide as an intracanal medicament if you're doing multi-visit root canal therapy. Okay, and here chlorhexidine is the key because the chlorhexidine is the one which is responsible for its longevity. It has prolonged action inside the canal, that is called as substantivity, and that is why we use chlorhexidine as the final irrigant in cases of failures. Okay, so there are various criteria for success. So there are something called as clinical criteria where we say that success if it doesn't have any pain, swelling, or fistula. We can say that the healing is uncertain if it is has a radiographic evidence of bone destruction. Okay, and we can say it as a failure if there is bone destruction, root resorption, and also symptoms. If there are symptoms present, then it is considered as a failure. Okay, yeah. Coming to reported healing rates. Now, if you see non-surgical treatment, the healing rates range from 74 to 98%. If you do only surgery and not do any surgical retreatment, it is 59%. But if you do both, if you do a repeat root canal treatment and coupled with apical surgery, the incidence of healing rises to 80%. Okay. So how should you go about doing the case study? Okay, first of all, radiograph is probably the most important step. Take a good radiograph, take it in 2 or 3 different angulations. Examine the signs for occlusal traumatism. Okay, if you see that there is bruxism, there is clenching, then yes, you need to be as certain and check that if there are any chances of vertical root fracture in case of trauma. Okay, if you find any signs, inform the patient that there may be a failure problem and inform the patient that this may fail because anytime the tooth may crack because of his occlusal trauma. Vitality of the adjacent tooth and just check for the vitality. If you encounter any failures, you need to check the vitality of the adjacent tooth because sometimes the adjacent tooth is non-vital and you are treating the root canal treated tooth. So if it is non-vital, you go ahead and do the treatment of that tooth rather than treating an old root canal treated tooth. Okay. Check for quality of obturation. Check for remaining structure, coronal leakage, and aesthetics. Okay. Whenever you want to apply any kind of retreatment, you have to see that whether the tooth is able to sustain the disassembly. That means this tooth may have a crown, may have a post. Okay. If at all you think that the tooth can withstand all this, only then you should prefer non-surgical retreatment over surgical treatment. Otherwise, you should go for a surgical treatment if you think that tooth cannot sustain the disassembly. For example, case like this. Okay. Yes, you can see that there is coronal leakage, the filling is not adequate. You see that there is a lesion developing, and the tooth is symptomatic. Then yes, you can think of cutting this crown off and remove the filling and going till the apex. Okay. Now here, if there is a lesion, that means there should be a canal till the apex. Okay. There won't be any lesion and there is no canal till the apex. So if you see a lesion, there has to be a canal at the till the apex, and which you have to negotiate. Okay. If at all you find that non-surgical treatment is going to destroy more tooth structure, it is going to compromise the structural integrity of the tooth, then surgical treatment is the correct choice. You can always perform surgical endo and perform a retrofilled MTA on the top. Okay. Another structure, what is more important for you is to know that there has to be a ferrule maintenance on the case. So there should be a facial and lingual ferrule. Now what is a ferrule? Ferrule is basically intact tooth structure, 2 or 3 millimeter tooth structure on the buccal and on the lingual aspect after the crown cutting. Okay, there should be intact structure when you do a filling on the top. So only if you have intact tooth structure of 1 to 2 millimeters in thickness and 1 to 2 millimeters in the length, only then you should go and try save the tooth. Otherwise, this case will end up in vertical fracture. Okay, what you should always check out is also you need to check out the crown root ratio. At the most, it can be 1:1. Ideal is 2/3. Okay, 3 parts of the root and 2 parts of the crown. But you can also save a tooth which has 1:1 ratio. So this is important to save the tooth. So facial and lingual ferrule is important. We can compromise with the mesial and distal ferrule, okay, because you have got adjacent tooth besides it. But facial and lingual ferrule are a must. Minimal 1 mm of ferrule wall thickness has to be there. Okay, if you see over here this thickness. Okay, this thickness has to be minimum 1 millimeter. Only then this will withstand the crown. Otherwise, this will break over here, and the tooth will en masse fracture within no time. This is what you need to know. You check it out before we advise the patient for retreatment. Okay. Yeah, if you come across an aesthetic case an anterior and if you find that the patient is having high lip line, okay, there are problems of black triangle formation if you do surgical endo, then you should prefer non-surgical endo. Okay, case like this. Okay, now you have a high lip line and you don't want to create these black triangles more. Now, if you do a surgical endo in this case, this black triangle will come till here and it will become more anesthetic. If the patient just may not accept. So in those cases, try to choose non-surgical endo over surgical endo. So when should you do surgical endo? If you find that there are overextension of filling materials, okay. There is a true cyst, okay, it's a very large cyst, but even today it's very controversial. There are so many healed cases that you will see large more than 10 millimeter size lesions, healing with just MTA placement. But if you want, if the patient is say going abroad, or you don't have the time for the patient patient cannot come back for follow-ups. In that case, we can always go for excision of the apical granuloma or the cyst, and the healing would eventually happen. Right? It's not going to prevent healing. So for faster healing, we can perform surgical endo. If you come across a vertical root fracture is incomplete, we can go for surgical retreatment. But if it's complete root fracture, obviously extraction is the case. If you as a patient have a long post, then it's difficult to remove these posts, so you can always go for surgical endo. Okay. If there are irretrievable broken instruments, okay, if it's beyond the apex, then you can go in for surgical endo. For non-negotiable ledge, sometimes you try very hard, but you're not able to negotiate the ledge. In that case, we go for surgical endo. Okay, so these are the proper indications. What advantages of non-surgical is that it has lesser risk, it's less invasive than surgery. Okay, it has less likelihood damage to the adjacent vital structures. The disadvantage of non-surgical endo, okay, is that it is far more expensive than surgical treatment. Okay, you'll use so many instruments; they're quite expensive, and they need to be thrown very fast because a lot of stress comes onto the instrument when you do surgical endo, and that is why it is more expensive. And the amount of treatment time required for retreatment is far more. So if you have a patient who doesn't have time, opt for surgical endo. Okay. So, yeah. So first step where we come is that we go. You have a tooth in hand. Now you have a crown on the top, or you have a filling on the top. So it's very important that we are going to remove this. So you better use a transmetal burr. So we use a transmetal burr like this, which is the right one is the money burr, which is transmetal burr, which can be used to cut the metal crown through. Okay, if you don't use a diamond burr to cut the metal crown, use a specific transmetal burrs to remove the crown. We can also use Money Super coarse burrs. Okay, now these are the new burrs which have been launched by Money. They're super coarse and they can cut anything, almost anything. If you just happen to come across these burrs, please use it once and you will love the efficacy of these burrs. Okay, if you can even see in over here, it has got very coarse diamonds. Okay, and it's very long lasting compared to normal burrs. And they come in various shapes and sizes as the way you have been using for so many years. It comes in all the shapes. They come in wheel. They come in tapered round. They come in tapered straight. They come in like pear shaped, even round burrs. So it's quite now. I'm a big fan of super coarse burrs, and because I have to lessen my inventory on all these. Okay, so once you have cut the crown, you need to grasp it, you need to percuss, or you need some active instruments on this. So we have certain something come with trident crown remover places that you can use. Okay, we've got KY pliers like these, which you can use for removals. Weinman crown gripper you can use like this after cutting the crown to remove the crown. Okay, or you can use percussion instruments. These are very popular in India. We are pretty used to these equipments like crown removers. They are the spring crown removers. Okay, then we have got Coronaflex is not available in India, but they are very good for bridge removals. As you can see that for bridge removals, it goes right below the pontic area and pulls up. Okay, so it has got a spring-like action and it pulls out the entire bridges. So it's very good for bridge removal. Okay, and this is probably one of the most common crown removals that every one of us has. Okay, but in my practice, I rarely use crown removers for such occasions. Okay, these are pneumatic crown removers. I use sometimes I've used Vanke. Okay, Vanke is a very atraumatic way of removing the crown, where you just make a slot in the crown, this over here. Okay, and there is an elevator kind of instrument which goes inside and lifts the crown up completely. So with Vanke, we can even reuse the crown and perform crown removals. Okay, but the easier, best way of doing it is probably just sectioning the crown and bending it and breaking it and removing it. Okay, we don't want to save a crown, we don't want to save the tooth. Okay, so we can always repeat the crown whenever you have done, but we cannot save the, if the tooth breaks off in terms of crown removal, it's not really helping us at all. That is why I will always prefer to remove the crown in this way. I'll show you a small video. Okay, you can see this burr. You can see this is like a money course burr we can use over here. Here they have used cut diamond. Okay, especially meant for zirconia, but we can easily use money course burrs over here. Okay, this cuts the zirconia crown very well. So whether it's metal or PFM or zirconia crown, you can go ahead and cut the crown. You have to cut it buccally and occlusally. Just keep observing whether you are contacting the tooth. You do not grind the tooth excessively. There may be a small slot which may come in, but that's completely acceptable. So you can see either you can use a angled elevator like this, or you can use straight elevator facing it at the buccal side. And you can see that zirconia crown, like Brooksie, breaks off so easily. Just about cutting the tooth. And if you have a mesial part which remains, we can cut it even into a third portion. So I think so you can see that this again you can put the elevator and we can break it off. So see the minimal damage to the tooth. Okay, so please convince the patient for a new crown. It doesn't cost you much. Always you can give a small discount to the patient for the crown, but save the tooth as far as possible. So crown removals are a strict no in my practice now. I was using it, but now all my crowns are removed in this fashion. Not less than 5 minutes, not more than 5 minutes. Okay. So that's where you will remove the crown. Next, you may encounter some filling inside the mouth, or you may encounter a post inside. Now, if you encounter a post inside, you have to know whether you have to know your judgment, how trained you are. You need to have the regular techniques. You need to know the techniques and devices, and you need to see whether the post is parallel, tapered, active, or passive. Parallel posts are difficult to remove. Tapered are easy to remove. Active posts are difficult to remove. Passive posts are easy to remove. Right? And if the resin cement is used for cementation, difficult. If you use a JIC, probably it's easier. If you have done it, you know how difficult it is. And if you do not know if you have not done it, you can take a chance. But if you are skilled enough to perform such procedures. Okay, more important is first of all, you need to identify the core and the post. To remove the core with the help of normal burrs and see to it that you don't touch the post at all. Do not thin the post. That's most important when you want to remove the core and the post. Okay, and we can vibrate out the post as we can see it in a video. I will just show some videos. Okay, tip is over here. Always keep it lubricating. Okay, or whenever you put any ultrasonic vibrations on the tooth, keep lubricating. Reduce the temperature produced because it may damage the periradicular tissues. So this is a graphic video. Okay, so this is a round tip ultrasonic post. Once you have removed the core, you will be able to access the post. This imparts some vibrations on the post. You have to move it counterclockwise, not clockwise motion, and keep wetting it. Okay, you not want temperature to rise around the root structure. When cement used, will start breaking because of the vibrations. So you can see it breaking. And that is where you will remove the break tips as well. Okay, so this is the easiest way of removing a post with the help of ultrasonic. vibrations. So these are the ultrasonic tips which can be used. They can be CT4 tips, you can have ET25 tips, you can use any tip. You can have tips like dental now, which are comparatively cheaper. So we can use these tips just to impart vibrations on the post. Okay, we can always remove some special bursts. Sorry. So we can there's some other bursts available where which can be used to expose the post, but I think ultrasonic is probably one of the best methods to remove the post. Another clinical video. So you can see a post, the entire core is removed. So be patient in your approach. You can see anti-clockwise. You can see it vibrating now. Okay, what you can see it in the microscope is clockwise, but it's actually anti-clockwise because it's recorded. You can see it vibrating. You can see it. Please keep the canal wet. And see that the post is out. Okay, I have a dam in place because you see the post flying out. We should not enter the patient's mouth. So please be very careful whenever you take out these instruments. So we have removed the post. If at all the post is broken, okay, in such a way that it is broken at the CEJ, then in that case you need to create a trepine. You have some trepine instruments like Masaran kit, and where we need to create a trepine around the post and then remove it. The other many post removal systems like these, okay, you can want to invest, you can invest, okay, if you are so keen, but I think ultrasonics are more than enough for its removal. If you come across fiber post tips, then you need to use something called a gyro tip. It's specifically designed to remove the fiber reinforced composite post. What it does basically generates heat, softens the matrix of the fibers, and removes the post. Fiber posts are very difficult to remove because they have been glued with resin cement. So if they've been glued with resin cement, they don't come off. It's very difficult. So in that case, we actually grind through the post, and this is one of the best ways because it softens the matrix and removes the fibers. Okay, and this is the way a fiber post is removed. So basically, a layer of plasma bonded silica carbide. This is this chemical which is responsible for reduced heat generation, and that is why you are able to remove the fiber post with gyro tips. Okay, this is the Masaran kit which I was talking about. Okay, it is complete kit. It has various sizes. Okay, from various strap-ins for it and for it to catch up, and then there is also an attachment to remove. So, but it is quite destructive on the tooth. Okay, so the use of these kits have reduced, but still it is quite available in the market right now. Okay. So there are potential complications for post removal. Fracture of tooth can happen. We need to keep observing closely. You see a crack, please inform the patient. We may perforate the tooth in a zest to remove the post, and if you come across the perforation, better that we schedule for extraction. Or if you're skilled enough, you can always go in and perform a perforation closure. Okay, so please inform the patient about that whether you'll be able to do it or you won't be able to do it. Okay, able to do it, well and good. If not able to do it, please inform the patient before. Okay, so now we have removed the crown, we have removed the post. Okay, and now we need to remove the gutta percha. So various methods of removing gutta percha. You can have K files or H files. We can use solvents. We can use heat transfer devices. We can use a combination. We can even use laser, or we can use specialized rotary instruments for retreat. That's probably the best is to use rotary instruments. You're also used to rotary instruments, and that is why we specifically designed instruments for retreat. Solvents which can be used are chloroform, are benzene, eucalyptus oil, okay, halothane, okay, orange oil, okay, anything can be used. Probably orange oil is one of the most popular right now. If you don't have orange oil, you can always use eucalyptus oil, which is available in any medical store. It's a partial solvent, while orange oil and chloroform are complete solvents. So I can always use solvents. Okay, these are the various trade names. We have got G-sol, Citrol. Okay, chloroform is not available in India, but available abroad because it's an anesthetic agent. It's not for sale in Indian markets. So that is why we use G-sol. Okay, but so what we do with uh, is that we use heat and head stomp file. Okay, we can always heat the Gataparcha with the help of a H file. Screw the H file inside, waited for it to soften over the or harden over the H file and remove it in one go. So that is probably one way to remove, but only if it's poorly obturated, we may come across that the whole mass of GP comes out. Otherwise, it will come out in bits and pieces. Okay. You can also use chemicals. So what we can do is that we can use chemical, put a drop of chloroform or drop of orange oil inside the canal and use wash winding motion to create space and then sorry having some cold, so I developed a cold right now. I don't know how it happened. So then we use wash winding motion. It creates a pilot hole inside. The liquid goes inside this place, and then we can actually maneuver our instrument inside the canal. So this is the file and chemical way of removal of gutta percha. But the only problem by using chemicals is that you can see that all the GP gets smeared onto the side surface over here. You can see uh, whatever GP, how much ever you remove, there is some GP which is stuck onto the walls, and this is very difficult for us for it to come off. And that is why we use only instruments for removal. Yeah. So we use heat to remove gutta percha sometimes, or we can use rotary removal of instruments like the Gaussian drill and the piezo removers, very popular to use. But the only problem is they are not very flexible. Okay, we have been using it for removal of GP for posts when the canals are straight in cross section or straight in their outline. We can use these, but whenever we come to complete removal of the GP, this has a limiting factor because it is straight, absolutely straight and not flexible at all, right? So for space, yes, you can use this, but not for complete removal. Okay. So we have the display file, D1, D2, D3. We have the M2 file, in which are made up of two files. Okay, we have the R endo file, which is made up of a round blank. Okay, and we have the GPR remover. We'll like to speak about GPR remover. This is also given by money, and it is one of the most economical file removal, GP removal instruments available. Basically, it is comes in a packet of four files. Okay, two are made of stainless steel files, while two are made up of the nitride files. Stainless steel files are meant for coronal removal of the GP, while the nitride files are meant for apical removal of the gutta percha. They come in sizes 70, 50, 40, and 30. So 70 and 50 are meant for coronal removal, and 40 and 30 are meant for apical. Advantage of this files is that it has a taper which is 4%. So there is adequate space for GP to come out from the sides if you have done a 6% preparation. It comes under various lengths, so we can easily approach the file pieces. Okay, and it's quite economical as well. If you see the cross section, okay, it has got deep grooves, but you see there are no side flutes available in this instrument. Okay, so what happens is that it only engages the gutta percha and doesn't damage the tooth structure. And that is why it is so popular, because the removal is so good and there is no additional damage or dental defects created in the walls of the dentine. Okay, so as I said, stainless steel file removal S1, S2, and NiTi files N3, N4 for the apical one. Okay. Uh, they have to be used at a speed of 500 to 1500 minutes RPM. Okay. And uh, it is color coded, so there is no confusion at all. Okay. You have the sizes according to the, you see the size, if you see, if the blue is for size 30. Okay. So that is where you need to be very careful, and black is meant for 40. So that is where the size goes. So if you remember blue, it will be size 30, black it will be size 40, which is ISO standardization. You see a small video of GP removal with the help of money GPR files. So you can see that there is coronal removal. You can see how beautifully the GP comes out. See how it comes out. Comes out completely coronally, and that is where the flute design is all about. Then you can size, depending on the canal size, you can either choose 3N or 4N. See how the GP comes out coronally and does not push periapically. That is the beauty of this design. And we recommend that use hand instruments to remove the apical debris rather than breaking instrument inside the canal. So apical 1 or 2 millimeters, you can always use hand instrument like number 10, 15. Negotiate till the apex. Be very careful of your rotary instruments in this zone, and that is why this is more safe removal compared to using rotary instrument directly at the apex. Okay. Some piezoelectronic instrument also available, but quite expensive. There is actually absolutely no need. You can also go ahead and use soft tissue lasers, but not really required NDR, because different lasers are required for different indication, and that is why you cannot go on investing on lasers over here. Okay, then we can go for yeah. There's something called braided file technique. If you come across any silver points inside the tooth, okay, so if there are any silver points inside, then we have to use a different technique like braided file technique, where we will use headstrong files and create space around a silver point, because normally there is a lot of space around a silver point. So we have to put one H file into one, second file into the another, and then screw it and then twine it so that the silver point can come together like this. So because silver point is not dissolvable, we cannot dissolve it. We create space around it and then untwine it completely and remove the silver point. This is far and few. Very few people might be now coming across silver points. It was out of the market 20 years back. But we in our practice, yeah, we did encounter some silver points during our practice. So this is what a silver point looks like. Okay, in the X-ray, very dense. It looks very good somehow, but it has its own failures of corrosion. So if at all if you find that such a silver point is extending into the chamber, then we can use a Stiglitz forceps. Okay, this is a Stiglitz forceps, silver angle. So remove this amalgam or composite carefully and hold the silver point over here very carefully and remove it. So we cannot use any solvent or anything over here. Okay, this is the way you will remove the silver point. The GP removal has been taken care of. Silver points removal has been taken care of. Sometimes the urban practitioners may come across solid core obturation. If somebody is using like thermopil or any of these obturators, then they have a central core which is either made of metal or plastic. Okay, so in those cases, if you are going to come across such a case, then what we will prefer is that there is a Stiglitz forceps which will hold and remove it. And if it's a plastic carrier, we can made up of two materials, vector or polysulfone. Made of vector it is insoluble, but if it is polysulfone, it would be soluble in chloroform. Okay, very few of dentists of will come across these kind of barriers. But if at all you come across, you have to tell the patient about its removal, and removal has to be complete. Okay, so we have to use system B, like a heat carrier to soften the gutta percha around it, and then we have to use files to remove it. Okay, so now once the GP is out, then there is cement inside the canal. Okay, now this space inside the canal, they also have to be removed for success of your retreatment in endo, right? So these paste normally harden over a period of time. So either we can use ultrasonics or we can use routine instruments to remove these cements. But okay, but probably Cephalodont has launched probably a liquid called Endosolve R. Okay, now this is a solvent which is actually even dissolve the cement. So if we come across resin cement, we can use these solvents to dissolve the paste. But if the paste is like really hard, then it is difficult for us to dissolve it also. So in that case, we use something called as a microdebrider. Okay, a microdebrider is like a fine instrument, a hard instrument, which is meant to penetrate these pastes. Okay, and where what we do is that we use these instruments like endo holder by money. Okay, they come across with these special files attached to it. So you have number 10, you have got number 15 along with it. You have a H type of file or K type of file. You can attach it, and they are very good to use under magnification, under microscopes for retreatment cases, for curved cases where you want to negotiate and remove, make a hold in gutta percha. So these are called endo holders, and they come across with various microfiles like type K files, type H files. You got even for flare files. They come various sizes from 8 to 40 as over here, and they have a stopper as well. Okay, but the problem is there is no need to hold the instrument over here. So that is why the visibility of your canal inside magnification is very easy and very good. That is why these endo holders are highly recommended. If at all you are using any magnification, it's a must for every practice. Okay, the material is mainly stainless steel file. Okay, so it's just like a stainless steel number 10 file or number 15 file, but with the attachment of a holder. So that is why the working with this microfiles is very easy and very comfortable. Okay, so there are various ways of you can remove these pastes. Okay, so this is where you will flush it with EDTA, with hypochlorite. You will make a pilot channel with these microfiles. Okay, and then only then we can introduce the NATA instruments to remove it. Okay, otherwise we cannot remove these medicaments or calcium hydroxide or any other paste in the canal. Okay, we can even use ultrasonic devices to remove these instruments. Okay, in short, we'll also cover up some broken instrument tips. This itself is a huge topic to cover up because, yeah, we do cause broken instrument remove fractures, and we also remove it. And probably every dentist, every practicing dentist will have broken instrument sometime or the other in their practice. So we don't say that it is a complete no. It does happen over a period of time. It is not something which is can be called as negligence. Okay, even the courts have ruled in favor of the dentist that if you break an instrument, it's not a crime. Okay, so please do not get burdened over this instrument. But yeah, our duty is to inform the patient always about instrument and to be kept in observation. Either remove it, bypass it, whatever you can do, you can always perform a procedure. Okay, so when should you discard replacement instruments? Whenever you come across any flaws like shiny areas or unwinding on the flutes, please discard it. The NITA instruments normally do not show such shiny, such unwinding or such weaker areas. So you have to monitor the NITA instruments very well. Okay, after 5 uses, please discard it. Do not be greedy and go on to use till number 10 or till it breaks. Okay, so more than 5 uses is more than enough for you should be using. Excessive bending and pre-curving. Okay, if you have excessively bent the file, then please discard that. Do not use it in the next case. Okay, if you encounter any corrosion in the on the instrument, please discard it. Okay, and especially if you are using any Spreaders or pluggers which have got defective tips or they have been heated, please discard them. Okay. Analyze the canal morphology properly. Okay. See that there is straight portion, there is a curvature portion. Okay. So mark that first. Okay. And if at all you come across broken instrument in a straight portion, it can be removed definitely. Around the canal curvature, removal is possible if you are able to see it. And applied to the curvature, it may not be possible. So you need to know that and inform the patient that this has to go for a uh, surgical removal of the apex. Okay. If the file is stainless steel in nature, it is easier to remove. Nitride files breaks again and again. There is a lot of secondary fractures because of its softness of the metal and because of the heat developed by the ultrasonic devices. So if you know this, you should be able to in a position to say that yeah, whether you will remove or you won't be able to remove the file. Okay, if at all you come across a coronal fracture, what you need to use is a gauge cleaner drill. You can see a photograph over here, and you need to just cut it at the tip so that there is a flat end at the tip. So this is used to develop a straight line axis to the head of the instrument. The instrument is broken over here, then there is a straight line axis. So we need to use a gates to get straight line axis to the file. You should be able to see the head of the instrument, only then you can remove it. Okay, that this definitely requires magnification. Okay, and once you have done the straight line axis, you have to introduce an ultrasonic file and create a trough around it. Okay, so this is what a trough creation is done with the help of ultrasonic file, and then this instrument vibrates it out. Okay, this is only done under the microscope. So if you have a microscopic view, only then you should be able to attempting removal of instruments. Okay, we have certain micro tube devices like the instrument retrieval system as well. Where staging platform is a must, we have to make a staging platform. But instead of electronic instrument, what is introduced is a micro tube. Okay, this is a micro tube. It is hollow. Okay, and a sharp end over here. You can see a sharp end over here, right? So the sharp end is introduced alongside of the instrument, and a screw wedge is put inside, and the instrument gets locked inside the tip and comes out. Okay, so this is called the wedging way of removal of the instruments. But only way when you can see it, you can do it. Now see, this is the way it is done. This is a micro tube, a screw wedge. You introduce a micro tube over here. You have created a trough. You slide it ahead of the pipe. Okay, and then you will introduce the screw wedge over here, and gets this instrument gets locked inside the open space over here, and the instrument comes out. This is a very popular method by Ruddle. Clifford Ruddle really advocates this microtube concept. He says that what can take half an hour, he can remove in 90 seconds. So this is what the beauty of this IRS system is. Other method is like wire and loop method. You have a loop which is of extremely strong steel. You have loops like Endo Cowboy or the PTR removal system, where you will need to have a loop which is passed on to the tooth, and the complete assembly is withdrawn from the canal. And this is the way it is. A diagrammatic representation of file. You unravel the 2 or 3 millimeters of file. You place a loop around it, tighten the loop, and try to pull it out. Okay, so this is the way a wire and loop method is done. There are various methods as I told you before also about Massaran-Kate extract kit, but these are very destructive. So now wire and loop and tube mechanics are the ones which are actually being more advocated than these radical ones. These are they destroy the tooth a lot. They require a lot of space for the instrument to go inside the system. Okay. Okay. There are other impediments also that you will come across in the entire root canal retreatment, which includes blood canals and ledge formation. Okay, so a typical picture you will see like this. If you come across a filling right up to over here, then you will actually come across that this apical part may be blocked, or there may be a some kind of ledge formation at the apex. So canal is curving on this direction, and there is a ledge which is gone straight over here. So management of blood canals, you need to first take a well-angled radiograph. Okay, see where the blockage is. As you can see, those two X-rays. You could see the curvature. You know where the curvature is, and you need to flood the canal with the help of an irrigant. Okay, and instrument it till the level of the impediment. Okay, this has to be done with the help of non-cutting instruments. Okay, and then most important is to pre-curve the file number 8 or 10 only and determine those sticky spots at the entrance of the blood canal. Okay, now this is the key. Pre-curving is the only way of bypassing the ledge. Okay, there is no other way that you can bypass a ledge. Okay, and this is ledge. If there is a ledge formation which has happened, pre-curving is the only way to bypass a ledge. And if you pre-curve right at the onset, you will not never create a ledge inside the canal. So you can see this is where the microscopic picture of this. You can see the canal curves like this, and the operator has gone straight. So this is where the ledge is. You will find a clear block. Now here, if you pre-curve the instrument will slide in over here and go into the canal space. Typically, you can see over here the ledge formation happening. So how do you do it? Locate the ledge, irrigate smaller instruments like number 8 or 10. Okay, you have to curve it, distal curve or the nasal curve, wherever the curve is. More often than not, the curvature is always distal, rarely mesial. Okay, and maybe buccal and lingual, which you have to gauge in the while doing the instrumentation. Then you need to recurve and put the silicon stops in that direction. Very important. Even a small curve will completely change the orientation. Start watch winding motion. Okay, and if a resistance is felt, okay, you need to retract, rotate, and if you find a sticky spot, stop over there, and you can go ahead with the watch winding motion. Okay, so pre-curve, small bend at the tip, and this is where your instrument is going to go inside the canal. So you require a lot of patience. Bypassing a ledge is all about patience, and I think everybody should be able to do it. Okay. Prevention of a ledge, yeah, we can always prevent a ledge when you're doing rapid root canal treatment. Okay. And the best way is to know the canal morphology, diagnose with the help of good radiographs, pre-curve, do not force the file. Okay, use instrument which has no cutting tip at all. Okay, and use modified instruments. Okay. Sometimes while during retreatment we come across perforations. Okay, and in those cases we need to identify whether perforation is large or small. Okay, and here we need to identify the perforation and close it as soon as possible. So if you identify a perforation in your case at the time of retreatment, please close it as early as possible. Consider that at what level is the perforation, where is the location, what is the extent of perforation, and what is potential for successful management. A very large perforation, okay, you are not going to go ahead because sometimes it is endangered the integrity of the tooth. Okay, coronal level, yeah, it is actually more failure rates, but if it's accessible and able to close, smaller the better. Okay, and more apical the perforation, better is success rate with the use of bioceramic sealers. Okay, okay, do we come across the how do you manage the perforations? Okay, we can use materials like absorbable collagen, like calcium sulfate. Okay, or we can use non-absorbable like MTA. Okay, MTA is one of the most popular methods. Okay, these are the barriers against which there is complete seal obtained, and it has also got osteogenic potential. So there is also cementogenic and osteogenic potential. When it comes to coronal, one third your perforations. Then first of all, you control the bleeding. Okay, if it is a smaller area, then always seal from inside the tooth. If it's a large area, it's better that it is sealed from outside the tooth, like a surgical repair. Okay, if aesthetics is a concern, we should always put a calcium sulfate barrier along with a composite restoration. Okay, and presently MTA is the material of choice for any perforation closure. So you can see a photograph here. Here you can see a perforation. You can see the canals are prepared well. So before we start closing we control the bleeding first. Okay, let the bleeding be controlled. Oozing bleeding, you should not close the perforation at that time. Wait at the same time. Do not send the patient. Wait for some time. Put a pressure plug. Control the bleeding. Then control the orifices. Keep a cotton pellet on the orifices so that MTA doesn't flow inside the orifices, and then close it with the help of MTA material with the help of pluggers. Okay, this is the way you will close the coronal perforation. Middle of the perforation is a bit difficult to do because access becomes difficult and repair is not predictable. Okay, but if you only come across middle perforations, the closure has to be done immediately. Barrier material of choice is MTA. So this is the way you will come across middle one third without a bleeding. You cannot see it, but when you dry it properly, you should be able to see a hole like this. Okay. Normally, it is commonly seen if the canals are in the canals. The roots are narrow. The roots are narrow. You will come across tip perforations anywhere over here. You can see over here. Many of the time we cause such tip perforations, and they are the cause of failures. Okay, especially the mesial roots of the mandibular molars and the mesial roots of the maxillary molars. You come across bleeding suddenly, then if you have crossed the tip perforation, identify it, and this is the perforation. This is the canal. So close the canal and cause a closure. Okay. If you have there is apical one third perforation, then the best way is to enlarge it completely and place a apical barrier like MTA at the apex, and surgery if the lesion is present apical to the perforation. Then we have to go for a surgery. There is no way that we can do it non-surgically. Okay, this is MTA commonly used. So a common surgical approach is combined intracoronal surgical approach involves repairing of the defect intracoronally. Okay, so that has to be done both ways, intracanal as well as surgical way. If you have a failing percussion, then you can either do a bicuspidization, or we can do a hemisection, or we can do an intentional reperfusion as well. The small video case presentation which we did in the college. Okay. This is a case of intentional replantation. It was a lower molar, long one. So this is where we injected. We saw a broken instrument inside the canal. So injected, extraction plan, elevation, then extraction was done. You see atraumatically extraction is done. Very long roots. You see the length of the roots, 27 millimeters. That will be dragging the socket to check its path of removal. The apex resected. Please hold at the crown. We can use a gauze to hold. There's a small piece of gauze between the hand. Then the retro preparation was done. We used an ultrason. We didn't use ultrasonic tape, but a burr because burr is faster to perform the procedure extraorally. MTA is placed at the apex, condensed. All this was done in the space of 11 minutes. Okay, and it was back in the socket. The occlusion was reduced, and the case was splinted physiologically. Okay, now this is splinting. We roughen that. Adjacent was also root canal treated. We had to restore that as well. But patient having severe pain as well in this case. That's why an emergency treatment was done. Acid etch, and a fiber splint was placed. cannot place a dam in this case because it's intentional replantation. So there is no way a dam could be placed. You can see the splinting process and this case splinted. Okay. This was a post-operative case immensely successful. Okay, so even these cases can be done if you have a failing case. The tooth can be saved, okay, post-operatively. This is after 6 months. So what are indications for these? Basically, intentional replantation can be done if at all you cannot negotiate the canal because of curvature, calcification, separate instruments, and you find that surgical will be more destructive. You can go for intentional replantation, and there is a large lesion. And if at all you have you have a sinus and a mandibular nerve below it, you can always perform intentional replantation rather than going for surgery. Okay. Do not perform intentional replantation if the root curvature is medically compromised patient or if the bone is compromised. Okay. So, to conclude, we can always perform endodontic treatment in single visit or two visits, the repeat treatment. But the conclusion was two visit endodontic treatment was always more successful than single visit in cases of retreatment. Okay. So conclude, in COVID era, every patient is considered potentially infectious. So we should revise the infection control protocols and keep us updated about the evolving disease. And that is why the first part of the lecture was dedicated to the do's and don'ts of during COVID practice. And the second part was all about retreatment procedures starting from crown removals to post removals to GP removals and knowledge of appropriate armamentarium desire to do what is the best, and that will give success in the long term. I would like to say thank you so much to all the listeners for this Idea Bilaspur branch who have been glued with me for 2 hours in total. And I'm thankful that there have been a lot of views as well as I've been getting the feedback. Hope you write to me if there's anything changes you need or you want something from my side or if I was lacking in any of my lecture discourse. And I would like to thank Team Idea Bilaspur for organizing a program like this and enhancing the level of dentistry. And I would like to thank Team Money for giving me an opportunity to lecture on this wonderful topic, retreatment in endodontics with COVID eras. And thank you so much. I would like to now take up the questions. There is some questions which have been come by Dr. Mehmood Shurab. What ultrasonic tips brand are you using? Okay, Dr. Mehmood, I've been using many ultrasonic tips. They range from Dentsply tips, Pro Ultra tips. The titanium tips, they are slightly expensive, but they are very good for instrument removals. Then I've been using the Anish Navre. Dr. Anish Navre had devices eye super tip that I use it for ultrasonic agitation. They are the cheapest tips in the market available. They come for 1200 rupees. Good for activation of irrigants. And I use Crick Dental tips for broken instrument removal. So Crick Dental is a moderately expensive ultrasonic tip, around 3000 or 4000 rupees per tip, but they are pretty good. So that I have been using as far as ultrasonic tips go. Dr. Mahmood, that's the answer to your question. Suparna Chaudhary, Dr. Suparna Chaudhary has asked, Sir, how to deal with patients who have been infected because they will be apprehensive about dental treatment, given the fact that distancing isn't a workable option at all. Yeah, Dr. Suparna, we will be coming across uh, apprehensive patients, okay, who have been infected. Okay, so as I told you, if they have been infected by any chance, okay, we need to wait till they have recovered from the COVID-19 disease. But once that is done, okay, they have recovered and good 7 days or 15 days have passed, then be rest assured that they are not in infective stage anymore. Okay, so that we can remove their apprehension as well as the apprehension in the waiting hall about if they know about the COVID positivity of that patient. Okay, and dental office I consider it as one of the safest places in the world today because we take all the precautions while doing treatment. We autoclave, we sterilize instruments, we use barriers. Okay, we are using suction high vacuum suction machines. We are using rubber dam. It is far less effective than going to a marketplace, than going to uh, grocery shops, or just walking on the road where there are no barriers available. So you can be rest assured that the infection spread from dental clinics is very less, and we really haven't come across any dentist suffering from COVID. Actually, the most in fact person who would be most infected because of COVID would be the dentist because he is encountering so many patients. He is going close to the mouth. So dentist to patient infection is very less. A patient to dentist infection will be far more. But we really have come across very few cases where dentists have got infected because of working in the clinic. So you as a dentist, be rest assured that you can, if you take all the precautions, you will be quite safe and I think you can practice with ease. So that is my option. Yeah, distancing is not a workable option. Yeah, distancing of 6 feet is always workable. Okay, 6 feet distancing is not a problem at all in your waiting hall. Always tell the patient to wait outside, come one by one, and have teleconferencing with the patient so that they don't just walk into your clinic. Do not encourage walk-ins. Always encourage that in the call up and then come for any treatment. So that's the answer to Suparna Chaudhary. Uh, I guess there are no more questions. But what I can see, Dr. Shivam is messaging. Mr. Shivam has messaged me. So can I call it a day? Thanking the ID team, Dr. Lakshmikant, Dr. Saurabh, and Dr. Priyanka. Thank you so much, and be in touch. Okay, if there's anything required, please let me know. Thank you.